I'm Member Engagement Officer at EATRIS. And just briefly, if you're not familiar with EATRIS, so we are the European research infrastructure for translational medicine, and we support researchers in developing their biomedical discoveries into novel therapeutic interventions to ultimately improve human life and quality of health. One of the key enablers of this translational journey, of course, is data. And we believe that the European health data space will be well positioned to truly become a cornerstone of European digital health ecosystem. In March this year, together with 38 other representatives of the EU health community, EATRIS co-signed the EHDS multi-stakeholder statement that urges policymakers to ensure meaningful stakeholder engagement and capacity building during the EHDS implementation. Currently, as also Justina mentioned, we are leading a project called EATRIS-CONNECT. It aims to accelerate the digital transformation of translational medicine across our 14 member communities. But digital transformation is not just a technological challenge, it's a human one. So in alignment with the EHDS multi-stakeholder statement, we believe that we're really well placed within the academic community to support building bridges between the digital and the human aspects of this challenge, and doing this through connecting and building the community with all the many stakeholders that are required for this process. This includes researchers, academics, clinicians, regulators, funders, policymakers, but of course, first and foremost, patients and patients' community, caregivers, and patient organizations. This is why I'm very happy to welcome you to this 2-hour event today to discuss patient involvement in the digital era. It's organized by our very sweet Latvian node, Rīga Stradiņš University, who is leading all the patient engagement activities in the EATRIS-CONNECT project. We have put together a really fantastic constellation of experts for you today to gain deeper insight into the challenges and opportunities of this journey. I would like to briefly list all of our experts today who will introduce themselves more later. Our keynote speaker today is Dr. Ildiko Vaida from the Dutch Patient Federation, and panel discussion will be led and moderated by the patient expert Baiba Ziemele from our Latvian network of patient organizations. Our panelists are Dr. Carlos Molina from Valdebron Research Institute in Spain, Dr. Begoña Nafria Escalera from San Juan de Deo Children's Hospital in Barcelona, Spain, and Maria Dutart, the Chief Executive Officer of EUPATI. Without further ado, I would like to give the floor to our keynote speaker, Dr. Ildiko Vaida. Please, the floor is yours.
Thank you, Elisa, and thank you all for the kind invitation. I'm really honored to get this opportunity to talk about the Dutch example of patient advocacy in this new world, in this new era of the EHDS. Shall I introduce myself a bit? I'm working at the Dutch Patients Federation for 5 years now. Before that, I was innovation advisor at the top clinical Dutch Hospital Association. And before that, I worked for 7 years in the patient advocacy for rare and genetic diseases at the Dutch National Umbrella Organization. And before that, I had a career in scientific research, first fundamental research on neuronal networks, then more applied research, also concerning AI and how AI agents are actually going to help us to deliver more tailored care for patients. So that having been said, I am trying to So I felt free to change the title of my presentation a bit, because after I have made the story, I felt this suits more what I'm going to talk about. So I'm going to talk about the national policy on secondary use of health data, in this new era of the EHDS regulation. And I will focus on our journey of patient advocacy and our tireless efforts to be part of this journey of EHDS. So this talk will highlight actually our journey, but it will also, I hope, give you a little bit of a background of how patients are included in the policy making in the Netherlands. So this will have also a little bit of a cultural flavor, I think. Yeah. So first, just a little bit of about our organization. So we are the Dutch umbrella organization of lots of patients organizations. Right now, we have 56 member organizations. A couple of them are themselves umbrella organizations. So in total, we represent around 200 patient organizations. These are the logos of them. So these are mostly disease-specific associations. What we do is actually that we give them a voice in the national policy making, in the media, and in the politics as well. So we have a dedicated lobbyist who is connecting us with the members of the Dutch Parliament. So what I'm going to talk about, I will just very briefly give you a very short overview of how the Dutch healthcare system is built up. I think this context is needed for the later discussion. Then I will talk a bit about the converging visions on secondary use of health data in the European Union and the Dutch system. Then there will be a part of my talk about patients and citizens and what do they actually want in this new era. How we tried to influence national policy once we were familiar with what these patients and citizens want. Then, by the end, I will talk a little bit about the current project, Health Data Access Body Netherlands, that is an ongoing project. And I will end by mentioning our place that we have fought for in the Societal Advisory Board. So the healthcare system in the Netherlands, it's a mixed hybrid public-private system. So there is universal medical coverage for all citizens, and everyone has to have a health insurance. There are like 10 health insurance companies, and those are regulated. That means that these companies are not allowed to make to give their profit away. They might make some profit, but they are not allowed to share it because it's not a shareholder system. So it's regulated by the government. And there is a gatekeeper so that people are not very readily going to the hospital care setting, and that is being kept by the general practitioner. The health insurance itself consists of two parts. Everyone has this basic insurance. It's a couple of €100 per month. And if you can't pay it, then you will be facilitated by some regulations that you will get money for that. And there is another part that health insurers offer, which are additional packages that you have to pay for, and that gives you additional health coverage for all kinds of, for example, dental health, psychotherapies, etc. the health data system in the Netherlands is very fragmented. So it is actually a decentralized system. It's by design decentralized. What means that there are data, and those are in silos, as you see here at the picture. That comes from the report of the OECD in 2022. They've written an analysis of the health information system and health system of the Netherlands. So the digitalization is at a very high level. Almost everywhere there are digital data. So no one is going around anymore with papers. But these data, they are registered in lots of different IT systems. And these systems are not able to talk to each other. So this interoperability problem is huge here. This is also what the OECD has concluded. So there are healthcare data in the hospitals, in the primary care, in the long-term care, social care, but also the public health. And these are kind of locked within their own systems. There are a few big players of IT health software providers, and they have quite a lot of power. Let's say some of them have monopoly, meaning that when a healthcare provider, for example, a hospital, wants to change something on the system to be more interoperable, to use, for example, international standards, then the provider is making it difficult for the hospital and charging a lot of money. So this is quite a problem. So when the OECD came with this report, the national policy makers and the Ministry of Health were already, of course, aware of this problem, and the first steps were already being made to take more control of the whole system and to make it more uniform and interoperable. And then the EATRIS was published, and that made a huge impact, because it served as a catalyzer for getting really things done in the Netherlands. So shortly after the EATRIS regulation, of the proposal of the regulation was published, there appeared a national vision and strategy of the health information system. That's what you see on the right. It's in Dutch. And this was really a breakthrough, because you must know that in 2011, it's long ago, but back then there were attempts to make it decentralized and to centralize this information management system and the data fragmentation to make an end to that, but it didn't pass the parliament. So it was since then, because of the political situations also, and the direction that all the governments were taking of, we keep things decentralized. People do not trust the centralized health data system. So we will let it go. And that is why it is actually, it became fragmented in the first place, because everyone went and bought their own IT system. And then at the end, you end up with a patchwork of all systems not talking to each other. So these visions converged suddenly. And then everybody woke up, and the work began. So what is in this national vision and strategy? it has 4 leading principles, namely, data are available. And it is actually available for all people who need it: patients, healthcare providers, policymakers. Also, for secondary use of data is available. The focus is on functionality. What does it mean? So the data is available, and private companies, developers will compete with each other, not on whether they have the data and can use that for development, but just on the functionality of their products. And all this will stimulate innovation. So if you are familiar with the EHDS, then you see that this is absolutely in line with what the EHDS is also saying. However, when it was published, the proposal, it had some consequences, because patients and citizens got concerned, because this term data availability, it triggered some thoughts on some dystopian pictures of having my data available for all kinds of purposes, and all my sensitive data will be out there, and people didn't really understood what it is about. So we realized we need to dig in more into this subject, and explain what it means, because we readily notice that these are separate worlds. So the world of the technicians, that they understand something completely different under the term data availability, and the citizens and the patients. So actually, there is a whole world behind this data availability term. So actually, for technical people, it means that data are only available after one has identified himself. There has been an authentication, whether he or she is the one who says she or he is, and authorization. Are you allowed to take a look in this data? So data availability is for those people like having data on servers that are approachable. So these are these shared servers. But how to explain this to patients and citizens? So there is our job. That is our job, actually. These are the pillars what you're seeing on the slides of the founding principles of the national strategy and the vision. So data availability is central. It's built on trust, and the governance is shared and inclusive and secured. So this trust is secured by binding agreements. So this trust is for us very, very, very important. So how to get patients, citizens, clients to trust this whole system? That's the challenge. Well, first we wanted, of course, to know what citizens and patients want, because we noticed these concerns. There was a real shock, like all my data will be available. But then we realized, and everybody realized, that the EATRIS is here to stay. We see, of course, the logic and the legitimation of data being available for all the good causes, for primary care, but certainly for secondary care, to drive innovation, to go to new medicines, new medtech innovations, etc. But it has to happen in a way that everybody sees this benefit and everybody is included who wants to be included. So we wanted to dig into that and to ask our panels of like 25,000 people what they think about health data, their health data that is being used beyond the direct care that they receive. So we put up a survey. It was in 2023, and more than 10,000 of our panel participants has filled it in, which is a huge number. So the focus of the survey was on control of your health data for secondary use within the borders in the Netherlands, but also within the whole Europe. So control over health data, it was about whether you want to opt in or to opt out. So how you want to give your consent. Just a little bit about the demographics of the respondents. It is absolutely true that our respondents are not representative of the Dutch citizens regarding age and education level. Most of the people are quite old and suffer from multiple chronic diseases. I did not include here all pictures, but most of them are also have a higher education level. But nevertheless, this is a good indication of the people who are very engaged in their health. The first results when asking about consent preferences in the Netherlands is that 52% of the people prefer an opt-in. So the question was actually if you would have a say, if it was upon to you to decide, would you like to opt in or to opt out for your health data being available for secondary purposes like research, innovation, and policy making. 42% preferred an opt-out. This is an interesting result, I think. It's a 10% difference. That also gives us a picture of and the understanding that people do see absolutely the benefit for the public health and for better health for all, but they are a bit hesitant because of all, I mean, that's maybe in the panel discussion I will go into that. These have some cultural aspects, but also some scandals that has happened in the Netherlands. So this is an interesting. Then the question, imagine that this opt-out is already in place, because right now it's still an opt-in. The opt-out, EHDS has an opt-out, and within a few years it will be in place. What do you prefer then? 64% said that they would actually like to decide case by case whether they will opt out or not. So what is this situational consent? They want to know the purpose of the reuse. Is it for cancer research? Is it for policy making? Is it for big tech innovation? Things like that. They also want to know which organization is the data user and what type of health data they are asking for. So this points towards a need for a layered, what we call a layered opt-out. So not just black and white, I'm in or I'm out. There should be more possibilities for choices. So with what kind of organizations do they feel comfortable to share their data? Well, hospitals were absolutely on the top, 92%. Universities, 73%. Government agencies, 29%. And the companies ended as last. Okay, then the conditions for sharing data when this opt-out is in place already. So there's a clear control what organization wants to reuse the data, the specific purposes that are also allowed in the EHDS, anonymization and security are key, and transparent processing and logging. The second part of the survey was about Europe. If you would have a say to choose between an opt-in or an opt-out, what would you do concerning secondary use of your health data within the whole European Union? It's interesting, but because here you see that 71% prefer an opt-in. So this is a much more, but bigger difference actually between Europe and the Netherlands of people who want an opt-in versus opt-out. Very similar is that if this opt-out would be in place, they would like to situationally decide 65% whether they will opt out or will remain in the system. These are the factors that they want to consider. Again, which organization reuses it, which purpose, what type of health data. And here, of course, we also asked whether you would like to make a choice about a country. So which country is asking for your data? And 37% wants it. So whether it's Spain or Norway, to have a choice there. So all the conditions that are valid for the Netherlands are also valid for the EU setting, but here some additional conditions are in place as well. So anonymity is a priority, secure handling across the borders, and there is a desire for all kinds of cell level of controls, and as within the Netherlands. The types of data in the Netherlands and in the EU are the same. So information about medication, treatment results, lab results, people don't have a problem with that. But when it comes to mental health, lifestyle-related data, and absolutely DNA, and I'm not showing you all the results figures, but just a summary. So here, the people prefer with DNA data, prefer an opt-in. The concerns: misuse or abuse of data, commercial exploitation without benefiting from the results, lack of transparency, and inadequate protection mechanisms. So there is a high desire for transparency and also for feedback on what has been achieved with reusing the data, what kind of impact has a company or the policy made, what kind of scientific development. People do want to maintain autonomy, is very important. They want to be informed. And this ongoing engagement is an absolute must. And building trust is also essential. After the survey, I've also organized, I don't know what I do here, but somebody's making some noise. I organized also several focus groups with our member organizations about these topics. And an additional condition was also that they want this trusting relationship that is very, very much present between the patient and the healthcare professional to be maintained. So this professional secrecy, what's happening, what I'm sharing in the consulting room with the doctor, people felt it's at stake if data will be available. Okay, then I'm coming to the part where we did have all this information, and we wanted to influence national policy, because EHDS is of course a leading regulation, but member organizations, member states have of course some space to fill in how will this implementing national acts will look like. So first of all, we published a position paper in 2023. There we said, okay, people prefer actually an opt-in for secondary use, but the EHDS is here, so we are for opt-out, but please consider the conditions and the safeguards. So all these things I just talked about. Then I've written in 2023 a policy vision and some recommendations of how, together with the patient movement, achieve data availability and trust. I will talk about shortly about that. And on the right side, you see an example of a lobby letter to the members of the parliaments. We are writing quite a lot of these letters, sometimes together with our sister organizations. Here you see the logo of MIND. It's the national umbrella organization of patient organizations, specifically concerning mental health problems. And I must say these letters make impact. Not always, but sometimes you hear the members of the parliament asking our questions to the government. So, policy vision and recommendation. The title of this is, if I translate it freely, trust takes years to build and seconds to break. Herein, we really wanted to emphasize what we call really the ethical fundamental principles of data sharing. And we build upon the health data governance principles. There are 3 of them. So in every case, wherever you reuse sensitive health data and lifestyle data and all the data that the EHDS sums, so protect the people, because even if well-intended, things can go wrong. Promote health value, that is the second one, and prioritize equity. So these are really the fundamentals. Then, based on our surveys and on our consultations and focus groups, we had formulated 3 conditions. So, trusting relationship must be maintained. So build a system of data sharing with opt-out, but please leave this trusting relationship intact. There should be agency of the citizen, of the patient. So an opt-out must be easily and readily accessible by everyone. And transparency is a very big one. So there should be transparency across the entire data life cycle. So from gathering, registering it in the at the hospital, which is a routine thing. So that's everybody knows that's even that's very necessary. But once that happened, please, for those people who want to know, give information. How is it? What is happening with your data? And of course, a lot of information on what, where was it used for, and about the laws and rules, and where can people go and complain if something goes wrong, so that the system is not really crunching them if their data are going to be misused, which probably will not happen. But please put these safeguards in place so that people already begin to trust the system a bit. I would also like to mention Health RI, It has a societal advisory board, and this societal advisory board is doing tremendous work and very good work on mainly on this agency aspect of what people need. So here you see a very weird picture. Maybe it's a tree with roots, but it is this is a metaphor for a citizen journey towards agency and transparent information. So at the roots, when a child is born, one can open a personal healthcare environment, as we call it, which is absolutely super secure, locked, and you as a parent have control, of course. And then as years go past, at some certain moments, there should be a notification like, okay, your preferred settings in this layered opt-out system, you may revise them. So, for example, perhaps when you were a young adult, you didn't want to share your data for, I don't know, for innovation purposes by medtech companies, but later on in your life, you might change your mind. So this dynamic consent is very important. And this is a very nice framework, and we would really like to try to bring it further with HealthRI. So just about a little bit more on the national vision and strategy. Of course, nobody thinks this fragmented landscape and data will, within 1 year, be fully interoperable and integrated. No, there are 3 stages that the national vision and strategy document differentiate. We are now in the very first one where really the basic things should happen. So now we are choosing for a common data model, for FHIR system, AP system, whatever, very technical terminology, etc. And as possibly always following the international standards. In this document, at every stage, it's really very, very nicely written about how to achieve these mainly technical, but also organizational milestones. In our vision document about trust, we try to integrate what we want to achieve into this national vision and strategy. So what I was writing is about awareness and inclusion in these years. So now we are writing 2025, and I must say the awareness is really beginning to manifest itself. So awareness about data, that it can be reused, that reuse of the data, if in a good way, good quality data, securely, really has benefits. And it's very, very important in this first stage to include citizens, patients. And in another stage, we think there should be more insight on how this health data access body is functioning. Well, as a digital literate citizen, to be, aware and to see the benefits, to see that companies, but also all other data users who are asking for data through the health data access body deserve our trust. So you endorse them. And of course, later on, this trust will grow as more and more good examples will show up. Then the health data access body. So we don't have it yet in the Netherlands, but by the end of 2023, a program has been launched. It's called Health Data Access Body Netherlands. And parties like Health-RI, National Institute of Public Health, the Ministry of Health is, of course, is in charge, but other institutions are also involved, are now busy with making the basic technical, infrastructural, things that are needed for functioning of the health data access body. And I've put here this scheme of the journey a data user is then making actually within the health data access body scope. So from data discovery, then access, then the preparation, and if the permit has been given, then the use of data, and of course, the finalization, using it, and hopefully making impact. Yeah. So I will not go into this program because, first of all, I don't know all the details. I know that there are 10 work packages, very technical, about secure processing environments, how they should look like, how this whole permit issuing should look like, etc., metadata catalogus, etc. This picture I've put in the presentation just to remind you that there are two parties, the data user who wants to use the data and the data holder who has some responsibilities. Of course, the data should be available if the data user is asking for it through the health data access body. Nowadays, we are talking quite a lot about with our member organizations whether, and if so, which of our member organizations are data holders. We think some of them will, the bigger ones, will certainly be because they have disease registries. And if you look at the list of all the data that are under the definition of the EHD as belong to the secondary category, secondary use, then probably quite a few of our organizations will be data holder. But these are things that we are now, together with other parties are looking at. So this is the system, and it's being built now. Then, and this is our advocacy work. In 2023, when this program has been launched, we really wanted to get on board. So I was really knocking on the door of the ministry, like, please let us think with you, let us join you, because we really think this trust issue is very important. So we were like running after the health data access body train, and I must say, at the beginning, there was a community here on the left. It's an online community. Everyone can be part of it. You make an account, and then you have a chat function, and you can give some tips and tricks or whatever, or your opinion. But it's quite, it stands somewhere far also for our member organization. It's not so personal, and also not at that level of engagement that we would like to have. And then, of course, these working groups of the program are very technical, but as in the opening remark it was mentioned, these kind of changes, system changes, paradigm changes are not. Technique is necessary, but it's absolutely not sufficient to build trust. And you have to translate the technical elements into what it means for the citizens and patients. And of course, it should absolutely be in some mutual product. so there was no place in this project for citizens, patients, and for broader public, but because we and others also were really pushing and didn't give up. Now there are 2 extra groups. So an expert group containing really consisting of all kinds of technical, legal, ethical experts, but also management. All kinds of expertise that is needed. And there is a societal advisory board or council I see here. And I'm very honored to be the chair of that. We just began a month ago. We kicked off. So this is a very good news that finally the program has embraced us. And in this society advisory board, there are few perspectives, that of a patient, chronic, but also with genetic diseases, rare diseases, also with different subsets, citizens in general, citizens with limited health literacy, healthcare professional, the healthcare provider, so the institution, industry, and the municipalities. So all these, where all these data are in the silos. And as a board, we are providing solicited and unsolicited advice to the steering committee of the program. And then I will finish also. This is my last slide. Actually, I think as a chair, I really would like, and this is also my vision, that this gap that exists between, the reality of every day and the lived experiences of the patients and the citizens and the fears and the hopes. So this will to connect with the world of the institutional logic and the policy system, because people on the left side of the cliff don't think in terms of primary use of data, secondary use of data. They think, okay, my data are there because I need good care and I'm getting it because it holds information for my good care. And for secondary, they think, I'm contributing to something bigger than I am. I'm contributing to a greater good, to good for others, for my fellow patients, and that these 2 worlds have somehow to come together. And I think only then we can end with a trustworthy health data access body. So it should be by design, and that means embracing all people who want to contribute and who can bridge this gap. So thank you so much. I hope, thank you for listening.
And thank you so much, Ildiko, for sharing your experience. And I think that now we have a time for a question. Baiba, maybe you have some discussion points for this excellent presentation and sharing experience.
Thank you.
Thank you, Ildiko. I'm absolutely thrilled by the experience you have in Netherlands, and I envy you a lot for having it, because that's a huge challenge to make it happen also in Latvia. For example, we have this digital health board, and patient organizations are involved in that one. But as you very nicely pictured it with the train runs, and sometimes I have a feeling that they are not very willing to take on board people who are maybe not that digital savvy, let's say it like that, because they have like their agenda. There are companies, there are hospitals and other stakeholders who want to make big projects and earn money on it, but they often forget that patients have to be involved. And I think today is a great possibility for us as different stakeholder groups to talk together and try to find the solutions for that. And I'm sorry for the background noises, I can't control that.
Thank you, Baiba. Thank you.
Okay, do we have any other comments? Yeah, Elise.
Yes, I was typing in the chat, but I thought maybe I can just ask it. So thank you very much, Ildikko. Very interesting to hear the presentation. And also, well, I happen to be based in the Netherlands, living here, working here. So very good to know more about, from my perspective as well as a potential, patient and a citizen of the Netherlands. My question is, I'm looking at the poll that we have here, and 80% of the participants are researchers, which is perfect because it's an event for researchers. Yeah. My question is, can you reflect a little bit on whether there is a role, and if so, what it is, for the researcher and the academic community to support in this process of trust building between the patients and the academic community for secondary use of data and with the policymakers as well. So if there is a role for academic community to assist in that trust building, and how do you see it from your perspective to take place or to go?
Yeah, thank you for the question. Absolutely, the role of the academic, but also, for example, top clinical hospitals who are also making a lot of research, doing a lot of research. There is absolutely. And I must say, this whole Health Arise, so that stands for Health Research Infrastructure program, that is now being, I think, for up and running for almost 3 years, is actually dedicated for researchers. So it's it gives lots of tools how to how to achieve a good position in this field, and how to cooperate with patients and people who are going to these academic hospitals and whose data are going to be reused. For example, there is ethical, legal, and societal information help desk. There's a website, and on this website, researchers can look all kinds of information of when to ask consent, how to explain when in the patient journey, about data. But also they can ask questions if, for example, some research is on the edge of being, having to have an ethical board review, but perhaps also not. So if you have questions, certain specific questions, you can ask that. So I would recommend to take to contact Health Arise for this, because that's the program, the system, the consortium for researchers. But of course, we are also open to join projects, but also to have some joint effort, perhaps also in the societal advisory board.
Thank you very much. And just maybe as a last comment on this, that I'm happy to say that Health Arise indeed is our Dutch node of EATRIS. So we have worked together very closely for the past 3-4 years already. Maybe in terms of other countries, I'm sure that similar organizations are also existing already in other countries as well, similar to Health Arise or something adjacent. But in terms of all our member communities from 14 European countries, I think at EATRIS we are also very interested in being part of this process and advocating for the patient voice as well, and obviously for the academic community. And as I mentioned in the beginning of this session, that this is exactly why we also stand behind the multi-stakeholder statement of AHDS to really advocate for this inclusivity of all the voices in the process. And thank you again for presenting the Dutch experience.
It was my pleasure. Thank you.
Okay, great. Thank you so much. And now I'm happy to give the floor to Baiba Ziemele, a wonderful colleague from the EATRIS-CONNECT project, and I think the dedicated patient advocate in Latvia and also in Europe. And she will be moderating the upcoming roundtable discussion. And Baiba, now it is your turn.
Thank you so much. I will start by introducing myself, just to make everyone know who I am. So I am a passionate patient advocate for more than 15 years now, and I have been in charge for Latvia Hemophilia Society, which is the patient community for bleeding disorders in Latvia. And I'm also building a national platform for all patient organizations for past 6 years. It's not as big as in Netherlands, but we are really trying. We have already 15 members, and some of them are also umbrella organizations. So basically, we have in this community around 30 different patient organizations, and I'm trying to bring them all the information and possibilities to engage in different areas, not only legislation. And yes, as Justina already said, I'm also being engaged internationally as a volunteer for bleeding disorders, for rare diseases in general. And since doing advocacy requires a lot of work together with national agencies and institutions, especially in the digital health, I must say that I'm a huge fan of personalized medicine and also data-driven decision-making. I was a market researcher, so bringing patient voice to the different tables is very important for me personally and also for the community. I see how it happens in Europe, and I really try to do it also in Latvia. So thank you for all the examples and having these great things that are happening already abroad in different other countries. And I have the pleasure to invite very distinctive panelists today. We already heard from Ildiko. We also have Begonia Nafria Escalera. We have Maria Duarte and Dr. Carlos Molina. And I will ask you all to present briefly yourself again, and then we will go to the discussion. Thank you.
Thank you, Baiba. My name is Begoña Nafria. I'm working at Sant Joan de Déu Children's Hospital in Barcelona, in Spain, and my role is to be the head of the patient engagement in research department. And as you can imagine, all this stuff about health data, in our case, it concerns to the parents, but as well it concerns to the young patients, because of course they have a clear opinion about the data stuff. Thank you so much for the invitation to be in this panel.
Maybe I can go next. So my name is Maria Duarte, and I'm the Executive Director of EUPATI. EUPATI stands for the European Patients Academy of Therapeutic Innovation. And we were originally an IMI-launched project, a European project, and now a non-profit organization based in the Netherlands. And we identify as a patient-led multi-stakeholder public-private partnership and an educational initiative. So we are not a patient organization, but an educational organization supporting patient education. And so our mission is to provide education and resources that enable patients and researchers to collaborate, co-create, and innovate, inspiring a collective global change and better health outcomes for all. And our materials cover the full life cycle of medicines R&D, so from the very early stages of research into medicines R&D and clinical research, but also the regulatory affairs, the health technology assessment. And in the past years, we've also added medical devices and now importantly also the digital health. And our digital health online learning module also includes an introduction to the European health data space, which is interesting as well in this context. But that digital health online learning module also invites the learner to learn about the key definitions to what is digital health? What are health records, telehealth, mHealth? How is AI? What kind of role AI plays in this space, and the use of digital health for diagnosis, for prevention, for treatment, but also how these systems are regulated and governed. So our role here really, and the perspective I'm bringing to this webinar is that of digital health literacy and patient education. And this is also my key interest in this area, to see what are the gaps of information, lay language information and education. And I was really interested in hearing, Ildiko, your presentation, and also understanding that I believe that information education has a key role to play in creating that trust between the different stakeholders. So I'm looking forward to the conversation today. Thank you.
So maybe I'm going next. So I'm Carlos Molina, stroke neurologist here in Barcelona at Hospital Vall d'Hebron. So I'm the principal investigator to a large European-funded project, the TRUST-Stroke project on AI in stroke, and then the Umbrella project, which is a IHI-funded project with more than 25 partners, industry partners and clinical partners. And also in these two projects, we have patients organizations involved and also patient advocacy associations. And a critical point in this context was the involvement of Nagar Health, that is a partner for UX that help us really to operationally involve patients, not only patient expert, but also the patient, the real patients throughout the stroke care pathway. So we learn a lot about that. We learn how to pragmatically involve patients. And the goodness of these two projects that is based on federated learning, that is a solution that allows to ensure data privacy and data security. So it builds really trust, not only in the healthcare professional environment, but also for patients. They feel comfortable that the data are not going to be shared. Data stays in the hospital, the algorithms that they are trained in a decentralized way, and also the access to the data is decentralized. So that way is our way to create trust, and the feedback from patients is continuous, and they are involved from the very beginning of all these projects. So in the design and conceptualization phase, they are part of this. So we feel really, really proud of what this journey that we are learning on the way, that I think we can contribute in the discussion. And thank you very much for this invitation to be part of this panel discussion.
Thank you so much. Ildiko, do you want to add something from your point of view?
Well, I've introduced myself, maybe just to let know that I'm also developing an AI e-learning together with our national education organization, also part of the UPATI. And it's about how patients can and should participate in the whole life cycle of an AI innovation, AI product. We are now finalizing the e-learning, but I think it will also help, because of course the first steps are data gathering and data sharing, and then afterwards, of course, the training, the implementation, etc. So maybe if the discussion goes in that direction on AI, then I can tell about this e-learning and what it contains.
That is fantastic. I think we will have a very fruitful discussion. We have around 50 minutes for that. And I see we have very different perspectives gathered today around the virtual table. And I was thinking all this morning from the presentation that in Latvia, one of the biggest problems is how to make these citizens and patients being involved in all these possibilities. For example, in our community, it's very difficult to find somebody who would be, I don't know, I'm the only one in my country who has done EATRIS training. And I think like I have tried for past 10 years to convince other patient advocates that it's like the most important thing that you have to learn and be on the, like to understand what's happening around and how to use all these concepts. But it's very difficult. And that's why we can't establish a national platform because of the small country and language barriers. And it's not like in Netherlands, in Spain, and in other countries where patient advocates are learning that much. And therefore, my question would be to start this discussion. How do you have any tips? Like, for example, Begonia, you are working with the patient parents mostly, and there's again different challenges as for patients themselves, the small kids, and also for the parents, because they have to understand it. They have to take the responsibility from about the children, and they also have to understand various health concepts and get engaged. Maybe you have some tips for us how you convince them to be more active and engaged in the research you do.
Yeah, I think that you need to work, let's say, in different levels. Of course, the EATRIS fellows, they play a very important role, but not everybody, can access to the training, even if it's in a small country. And I think that the role of the EATRIS fellows is to go, deeper in each country or disease area at national level and, educate, the rest of the community of patients. But of course, we cannot tackle with 1, 10 or, X EATRIS fellows, all the communities of patients. It's going to take a lot of years. Having said this, I think that it's, let's say, a social responsibility of all the stakeholders, people or experts working in the research setting, in hospitals. We need to be part of this educational process of the patients and the families, because it's not only a matter to explain a research project, go through a consent process and involve participants in research or in any other setting in the medical field. I think that we need to have the right capability to explain what means, in this case, the use of your data. And specifically in the communities of patients that we are working with, the parents, in this case of children living with rare diseases, they are very prone to share data. Usually they have, knowledge about the rights that they have, because they are very, let's say, educated, and not only in the disease area, also in regards on this stuff. And they are very, as I said, prone to share the data, even with the means or the channels that are not the right ones. They publish, sometimes diagnoses, medical records on the social media. This is something that also we need to address, but I think that we have, at least in the pediatric setting, very well educated parents, caregivers. In regards of the young people, as I said, they want to contribute to any decision that can matter their health, and they have a very, let's say, realistic opinion about what they want to accept or not. But it doesn't mean that we don't need to educate them. We did a pilot project time ago with the schools, because I think that as well they play an important role in the young people, because at the end, data, it's about health, but it can be about, in the digital world that we live, about any other, proposal of use, not only about health. And I think that it's important to work and include probably these topics in the curricula of schools, because we need patients well educated, that they can take the right decisions about the use of data. And I think that an important player on this are schools. And, everything is moving to data. And I think that we need to try to push and move forward all these programs, specific ones about health, and to empower key opinion leaders and advocates at national level, such as the EATRIS training. But there are many other ways to ensure that our communities of patients, they have the right capabilities to take decisions.
I absolutely agree to you, because I see the huge difference between the countries. Like when we read research about health literacy levels, then the Western Europe is absolutely like 3 times better than Eastern Europe, and there is still huge amount of work to do to educate people about different things, not just like being active and becoming patients. Maybe Dr. Carlos, you can tell how you use this. You said you engaged not only patient experts, but also regular patients in your work, and how it helps to make your products better.
Yeah, it was by design. I think in both projects, Trust, Stroke, and Umbrella, we envision to have always patients from the very beginning, and NACA help us in different hospitals because it's a European-funded project. So we started working in Leuven, Gemelli in Rome, Leuven in Belgium, and here in Barcelona. And we identified focus groups in different hospitals, and then expanded to in different, not only the big hospital, but also the small hospital dependent to this big hospital. So working with a focus group, implementing a digital platform for patient education. Not only is the patient, in the case of a stroke, is the caregiver. And also there is a plan for training, similar that as mentioned before in the schools, is the Angels project. It's a project for using cartoons to teach the kids, how the symptoms of a stroke, how to react, how to activate the stroke code if your grandpa, your grandma has a stroke. This kind of vision. But the engagement project was to go down with the help with the hospitals, just identify different groups of patients with different, you realize how different are the health literacy and also the digital skills in different regions based on the socioeconomic status of different areas. That's important for at the end of the day, for the embracement of the solution. So it's not just the design, and it's nice to say that we involve the patient, but at the end of the day, the best KPI is the level of embracement. If they use it, if they really feel comfortable with this, and they contribute on that, they continuously can reshape the solution. It's not only the beginning that, okay, you are there and we can say that we have patient engagement. No, now with the large language models and these new technologies, and these are evolving solutions that we need really the patient really involved. So with this study, especially with Trust Stroke, we identify some user personas. So not all the patients are the same. Some of them are more engaged with digital technology. Some of them are more prone to perform a better secondary stroke prevention and treatment adherence, for instance. Others not. So we identify 4 types of user personas. So those who are really good patients, let's say they are really engaged and are really good in digital skills, they need a low level of supervision, let's say, for digital implementation of the digital platform. And on the other side, there are patients that are more lazy, let's say, or they need more support. They need more. It's just they are like this. There are not other way to engage them. For instance, for treatment adherence, that is very challenging in cardiovascular diseases. We need a really high level of patient engagement, treatment adherence to avoid recurrence, and they understand that they can track their own levels of engagement and adherence and see simulations. So what you are in the good track, follow this path and you will reduce the risk of recurrent stroke, for instance. This is something that is interactive and with different customizations for patients from one side and from caregivers from the other side. This is our approach. In Umbrella, we just kick off like a few months ago. So the idea is the same, have the same approach for patients and healthcare professionals, and also expands to other citizens that are in some way or the stakeholders involved in the process.
And do you involve also patient organizations in that?
Actually, we articulate the connection thanks to patients' organizations. Patient organizations, we have the European, the SAFE, the Stroke Alliance for Stroke in Europe, that articulate with local patient organizations that are from the very beginning with us, just we learn from them how to approach better the patient, not only the expert patient, because the expert patient has a high level of knowledge that it not always represent the real patient. So we need to know the real patient, the paradigm, the old patient with the stroke. This is what we need, not the literacy patient, like the expert patient. But the personal organizations are essential here.
You need both. I see you have your hand.
Yeah. You need both for the design, but it's my perspective that the patient expert is too expert. It's almost as a physician. They are very knowledgeable at the end of the day. They learn a lot. And they see things that they are not the real need from the patient. They used to be patients in the past, but not anymore. It's like, sometimes it's like that.
Yeah.
Maybe this is my
Yeah, I like what you say, if I may, Baiba, interrupt. I see a point, and I absolutely agree. Look, I'm a patient advocate. I'm not used to be a chronic patient. So for me, I'm a policymaker, but I have to realize, and I do realize, that for engagement, for really, getting out that is really lived experience, I need the real patient who have survived the stroke, who has a relative who had the stroke, who is at high risk of having a stroke, etc. And I'm happy that we have this huge panel and that we can kind of filter them. So we always ask them, okay, who is I don't know, a certain age, experience that, disease that, a relative, young, old, etc. And then they sometimes we have hundreds of people who want to cooperate, who want to share their experiences. And that's what we need. Why? Because I think they know what's ethically right also in their situation. I'm not knowing that, but I think being aware of this is very, very important. And if I may just reflect on your question, Baiba, like, do you have tips and tricks? Well, maybe it sounded like everything is perfect in the Netherlands. That is absolutely not. I hope I also gave you a little bit of a taste that we have to fight for our place. But I'm also like for 15 years in this field. What I notice is there where you make engagement systematic, part of the system. This policy world, these people in suits standing on the cliff. So people who are really far away and stand far from the lived experiences. If you make part of the system, then it will happen more quickly. So the first step, I would say, try in Latvia to make patient engagement part of the system. So the first step, as Maria said, education. Education is very important. But if people feel that they follow all kinds of courses, they got all kinds of diplomas, patient advocacy, and they cannot use this knowledge because the system shuts the door or nobody listens to them, they will not follow it. I mean, so I think that's as simple as that. So that it's worthy of doing these courses or making these courses, because you will have a role, you will get a role. So that's I just wanted to add that I think that's very important. And here in the Netherlands, we have a system for clinical guidelines development where patient engagement and participation is a need. Otherwise, your whole document, clinical trial with all clinical guideline with all the evidence will just not be accepted by the National Health Institute. And we have the new reality of medtech, of digital devices, of MDR, of all these medical digital innovations, where we do not have this yet. And I'm really fighting for having the same system. So patients included in the development and implementation of digital tools. Certainly AI.
I absolutely agree. I think one of the biggest problems in my country is that I'm a fan of citizen movement, that we have to be engaged, we have to be responsible for the things that we want to change. But the environment, somehow in my feeling, they are going directly to the patients, and they often forget that we have to be organized in patient groups and also have kind of like, because sometimes they find a patient who is not a part of community, and then the community, which has this level of knowledge that we have built for many years, that then it somehow is not used. And I'm very sad when I see that happening. And we have had some situations in which some of the stakeholders go directly to patients who don't represent the community opinion. And then we can sometimes lose a bit of what we could gain. But I see, Maria, you have your hand up, maybe.
Yes, thank you. There are many, many important topics being raised here, and it is a topic that deserves several weeks of discussion, I'm sure. So I hear that one of the items here being discussed is information education as part of that awareness building of what is happening now at the European level. And there are many initiatives here. We could name one that comes to my mind is a very recent one by the European Patients Forum. They have just published a toolkit on the European health data space a couple of days ago, and that's a very helpful toolkit for patients and patient organizations. So I think in this awareness building effort, there are many positive things that can be highlighted. Patients can benefit here. They, as my co-panelist said, can become owners of their data. They have greater control of that data. But there is also a risk that we leave a group behind. And you all have heard about digital divide, and this is something that still exists even in developed Western European countries, but also is related to different age groups and some disease-specific areas. So when we get very excited about digital health, I think it's also something to keep in mind that accessibility is something that we need to promote in all of the technical development and technological development, and I know you know that all very well. But so I'd like to kind of leave that awareness building space towards more research focused discussion, because we understand that this new developments open also up new opportunities for research. So the secondary use is very exciting, and I think the creating and transmitting that excitement to also patient communities is our role, and do that in with transparency and that trust building at the same time. From EUPATI's perspective, we focus on patients' role also in digital health in the co-creation of these new solutions and the research activities. So our challenge from EUPATI's side is to prepare patients and patient communities in this new role. It seems like we have just understood what patient involvement is, let's say, in the more traditional clinical research. We have our roadmaps. We have started to really understand what the different endpoints are where patients can provide input. And now it's a new conversation. It's a new world. So now what does patient involvement mean in what it means in the digital era? What does exactly what Ildiko you are doing for the AI solutions, digging into the key steps, the different endpoints where patients need to be involved and can be involved, but also where they need capacity building efforts to be involved. I was yesterday in a kickoff meeting for a large IHI project called GREG, which focuses on real-world evidence for regulatory and HTA decision-making. It's also a new area for patients to be involved. We are asking ourselves now questions, what does it mean for patients to be meaningfully involved in that kind of studies, those kind of studies that take on real-world evidence, and it's fascinating. But we are still sort of navigating in a new area, a little bit in the dark yet. So maybe I can. I don't want to take by your role as the chair, but I'd like to hear also other views on this. Thank you.
Yeah, I want to make a comment on top of Maria's ideas. Of course, for me, education, there is no discussion that it's needed, because we need this education as a patients, to be involved in these discussions and in these decisions. But about specifically the patient involvement in general, but as well in anything that can be close to data, IT, and innovation. Still, sometimes we are approached for activities in which the patients probably they don't have the right skills, or they don't provide, any added value. And I think that this needs to be meaningful, not a tokenistic exercise. And yesterday it came to my table a project in which a biotech company was asking to involve children to design, a specific IT solution. And what they were asking is to have, let's say, a role like a partner with IT expertise. The patients, they don't need to have an IT expertise. They have the expertise of the disease. They have the expertise of the teenagers, caregivers, whatever the role. And I think that in some, moments of the development of these initiatives, sometimes there is not proper or meaningful use of the contributions of the patients. And I think that the people working as an expert in patient involvement, we need to ensure that we are, involving in a meaningful way and providing an added value, not only for the project, as well for the patients. And around the discussion about data, there are many, let's say, gray areas in which probably we need to take care about what we are asking to the patients' communities.
Yeah, I'm saying, go ahead.
Yeah, who me or Carla? Yeah.
Yes.
Okay.
Well,
yeah.
please.
Thank you.
Go ahead.
I was triggered by what Maria said, but also just now, what kind of expertise patients actually need in this digital era. And my experience in my project is, indeed, they don't need this big, huge technical expertise. That's not their added value. It's the lived experience and the moral values. But I must say that some very, very basic knowledge is needed. Otherwise, you don't know what you're talking about. So if one doesn't know that what a model is, and that algorithms are being used to train the model, and then that you have the deployment phase, then you will not be able to talk about the challenges that these phases face when developed. So I think we need, just as we have, for example, I'm always coming with these clinical guidelines, but we have such a huge experience the past 15 years on co-design and co-developing clinical guidelines with healthcare professionals. There is this GRADE method, and the EATRIS Evolve organization in the Netherlands is giving courses on GRADE methods for patients on their level. How do I, as a patient, evaluate evidence, scientific evidence? Okay, that's you should say that's a very, very how shall I say, high level knowledge you have to know. Some people do have to, and you also have to think, in which phase of the development do I need this knowledge, and where do I indeed call the real patient, who is not a patient representative, but who will share the experience, and from who you will learn how it is to live with the disease, but also what kind of path the patient is going through in the healthcare system. So I think we need this method, and I can talk another time about a project of us in which we co-created AI innovations with patients, also real patients, and not just patient representatives, based on the so-called value-sensitive design, which is a design method, if you want, that during the development of the innovation integrates technical but also social requirements into the design in a way that these ethical requirements will be met. And what are ethical requirements? Those values actually that patients, healthcare professionals, but also developers and share. So this is based on consensus. So I think we should also go more toward this methodological discussion of how to co-create together digital tools.
Yeah, I wouldn't agree more. So what you just said, so I fully agree. So for the co-creation, not only from the co-creation, but we think that the co-creation is the beginning of the process that continues. So especially now that the digital solutions are evolving with this reinforcing learning process. So the patient has to be involved, and we need the average patient that is representative of our population, the low socioeconomic standard, even those without digital skills that in the future will have digital skills. It's our work to work in the literacy of the population and the citizens. So we need to ensure that we will avoid bias. Otherwise, AI will amplify the bias, the existing bias. That's why we need to involve patients that are real patient average. Even the old lady who has a minor stroke, she has just a phone, she used the WhatsApp. It's enough. Fine, good, you're welcome. So your contribution is super important, because more in the interface, in the end user perspective, the interface of the smartphone or the platform, what do you use? Or you don't want to use it, you prefer to call the case manager at the hospital. This is your decision. And we need to accept that. We need to embrace. I think over the next 15 years, our solutions should be hybrid, so not fully digital. Otherwise, we will miss patients. They will be out of the system. And this is the risk. It is the same for the finances at the bank. So we have people out of the system that we need to embrace more people. And in this process, in this 10, 15 years, I think more and more patients will contribute more in this process. They will be more used to be involved in this process. Like now in the sharing decisions, for instance, clinical sharing decisions, we have patients that they are used to have these sharing decisions. In the future, they will have this sharing collaboration, this sharing, they will participate more actively in the co-creation, the full life cycle of the solution, and especially with the eruption of this large language model. It's like never-ending process. It's a never-ending process. So it's not just co-creation from the beginning, it's the readjustment, it's the continuous feedback. We need the continuous feedback, because the initial solution will be completely different than the same solution 2 years after the initiation of the project. So in a sense, we need normal, real patients. We need to make sure that we when we approach the patient organization, they say the same question: what kind of patients do we need? Average one. We need the severe stroke, moderate, mild stroke, all young, poor, rich, different areas, and also both different languages. Because the solution is not just, especially in Europe, it's not just a single language. Not all are fluent in English, or you need to involve the local language, and also you mentioned also the values, but also the mindset is different. For instance, in Belgium, and some areas in Belgium that in Italy and in Spain. So we thought that we are similar to Italian. No, we're different. We are different. The post-hospitalization approach is completely different. The family organization is completely different in Italy than in Spain. And we thought we are the same because we are South Europeans. No, we are different. We missed that part. And now we pretend to implement these solutions for everybody and to sell it for everybody. No, it's not for everybody. I'm sorry. If you miss it from the very beginning, you cannot embrace everyone in these solutions.
Absolutely. I think and here in the Netherlands, it's now also in the integrated healthcare agreement, we stated with all other parties, hybrid care pathways. So it can begin in a physical meeting or maybe through online. Sometimes you go to the hospital or other organizations. Sometimes somebody will cycle to you with the chemotherapy, which is also here in the Netherlands. Nurses bringing the equipment to the home. So this hybrid. But when to use hybrid, and then when to use digital tools, and then the opinions differ because digital is. It's a kind of hype. Everybody should be digital savvy, but we are not techno optimists. We are techno realists. Indeed, if somebody is not able, not willing, or just don't have the devices at home, then you can't force these devices. Then we should really have a tailored care path. So we are working on it, but it's not easy because the system is having a checklist like this is the protocol and this is how it should go, and then to have attention to the person in real life with the real problems and with its environment is not always easy to achieve, but we're working on it.
Fantastic. I hear throughout all your stories the same thing, that the lived experience of a patient is extremely important, that there should be somebody who is giving the hand, should it be the researcher or the patient expert or somebody else involved in this co-creation, so the patient is not left alone or doesn't feel like less competent when they have to speak together with these, whatever people who are doing the research or other programs. And one more thing, that technology is not the end, it's the means to get to the result. So we all have to work together to find it. And I will use the rights of me as a moderator, and I will read the first question we have on the chat, and I encourage people to do questions also in the chat. So in your work, have you noticed the difference in trust levels of patients between different countries? And is there a trend stronger between different age groups? Let's say older patients trust less, or have you seen it in your experience? And you just start talking.
I don't know whether the question is for me, but our survey was aimed at the Dutch population. So we did not a comparative study among European countries. It was just within the Netherlands and all Europe. So unfortunately, I can't answer this question.
So in our experience in Translational, we did this work. Actually, it was a specific task of the user experience UX partner. So they went to the field and they perform a study in the population in Leuven, comparing the population in Leuven. It's a neighborhood in Europe with the corresponding area of the catchment area of the hospital, same in Rome, the Gemelli and Weidebronn. Different patient population from the socioeconomic perspective and from demographics were different. So you saw clearly the difference in terms of engagement, in terms of trust. So Leuven, the system was well developed. There were wealthy people. Of course, the level of literacy, digital skill, and also trust on the system, trust of new solution. They were eager to participate and be part of this digital program was higher. And then when it was Weidebronn and then Gemelli. So and it clearly reflects the demographics. So older people in Barcelona and Gemelli, younger people in Leuven, so higher level of literacy, also a higher socioeconomic status. I think this is the non-determinant of health are really relevant here. But it is, and we miss that. It's not just, it could be in a different neighborhood in Belgium would be different or similar than here. So we need to stratify, taking into account not only age, but also the economic deprivation, for instance, the level of economic deprivation. We need to know this information and explore more, not just age, because there are all people that are well literate, and also they are good in digital, they have good digital skills, and young people that they're not accepting that. Now they are like scary about new technologies. This new fear on technology, and when you are sick, even you're a patient, so it's even worse. That we saw that difference, and the main difference, I would say, the two ones is age for sure. The older you are, the less trust, and because you don't know about the solution and the potential threats that will come with your data and so on and so forth. And also the second one is the socioeconomic status, and it's across different European countries.
Yeah, I agree with Carlos about the importance of the determinants of health, no? And all the declination of the concept of diversity, because basically this is what makes, the people have different levels of trust. And also I want to comment in regards how the different initiatives are designed. Probably the health system, of course, it's the same in the country for everybody, but not everybody has the same means, to access to this public health system. Still, elderly, they don't have internet in the mobile, and we have an app to consult our medical health records in an app in our mobile. And this difference is, internally in a country. Also, we can see when we go beyond and with some specific countries. I remember some projects that we did in collaboration with South American countries, in which we were asking, patients and families from there to complete questionnaires using an online tool, Easy Think. But the problem that they had is that depending where they live, they didn't have access or connectivity to internet. And of course, if you never have access to these tools, you don't know how it works, you don't have any, education or any clue about which are your rights and how you can take decisions on the use of these technologies. And another example, it's about, for example, the use of wearables and devices. Still in some research projects, we are asking to the patients to use their own device. Not everybody, they have an iPhone, and we can read clinical trial protocols that they are requiring as an eligibility criteria to have an iPhone, for example. I think that it's a matter to have a balance between the diversity of the populations that we are working with and how we are offering these tools, because if these tools are also an element that can discriminate the access to the citizens, I think that the approach that we have, it's not the right one. It's not, as we comment before, it's, a reason to exclude, to have the same, equity and access to everybody. And it happens, even in, high-income countries in Europe. It's not a matter about, in general, the country. It's a matter about the diversity internally at country level. And of course, when we work internationally, probably it's more easy to see.
Maria, do you have something to add?
I don't unfortunately have this kind of country data either, so it's very hard to comment. But I do appreciate that Begonia's comment on that. What I also call digital divides. That we should be aware that not everyone has access to these devices, and that confidence also that's needed often to use different new solutions. It is not self-evident, so it's important to know.
I think you all made sorry for the noise, very valid points. And I also think that we have to come back to Ildiko's slide about transparency, because I think that's the most important. When we have to build trust, we have to explain people why we are gathering data, how we will use it. And I think only then we can, then people will start sharing. For example, I always recommend something when I see it's like when somebody has explained very well why they gather the data, how they will use it. And when I see some, I don't know, even survey results implemented into some actions, I always recommend other people to participate, because I see that the benefits of having this being part of all everything that is happening. So we still have like 10 minutes. I was thinking maybe you have like some points that you want to make, and without, like, definitely you have to tell them before you leave.
Maybe I can come in there with this question of transparency, and I want to highlight the role language plays here. And we from EUPATI have this long track record of developing lay language materials and accessible materials. And now I am very excited about the new developments that these language models, AI, can also help us with in sort of translating very complex information into a more accessible style. And of course, there are risks, and these needs to be also verified by humans and experts. But I think it's an opportunity to learn a new language that is then easily accessible to different groups, and it can also be tailored to different kind of audiences. And this to me is a very interesting topic at the moment, because I believe in the power of language and communication in building that trust and transparency.
Yeah, I agree absolutely. What I noticed also in my project on AI, that patients really, and that's why we actually also developed the masterclass and then now the e-learning on AI. People don't have the words. They need to learn the words to express themselves in this new digital era, and certainly about AI. So what does it mean, these ethical requirements? Then the whole system of training a model. We always use metaphors, like an algorithm is like a cooking book recipe. With these kind of analogies, you can really make things going to live in their heads, and then they internalize the subject, but also the content of the information that they really internalize and understand it. So I agree completely. And about this transparency, I think it's very, very important. But what we often hear in our discussions with, for example, the industry, but also politics, is that too much transparency is undesirable. And I am very, very interested in your opinion about whether too much transparency exists, and if so, what do you think? Why actually, if it exists? What we hear is always, the intellectual property should be safeguarded, but also having the time and the space to contemplate on certain, policy decisions before throwing it out there and asking for everyone's opinion. So I think it's a delicate balance how transparent you might be or should be. So what are your thoughts on that?
Yeah, I agree. Too much transparency could be like a boomerang effect, at the end of the day. But transparency, I think, is important, not only transparency, but also explainability. We also we hear about the explainability every day, but this focus on healthcare professional, how we can embrace the solutions. We understand what is beyond the black box of the AI. But we also need to start thinking on explainability for the patient. They need to understand why it's important for them. What is the AI is working, and having this mathematical formula, what is behind? What is the link between the question and the input and the output in a simple way. Yeah. But they need to understand, okay, it's not magic. It's just they deal with a lot of data, and they summarize my data with together with the recommendation that they have this recommendation for me, so I can follow it. I trust. And we need to start building trust.
Absolutely. This is what we are we'll try to convey in our e-learning, because this is exactly in how to interpret the output and what is the rationale, what's the logic. I mean, this is not a mythical, magical thing. It's indeed mathematics and how to convey that information. So indeed, Maria, it's very important to use the right words, the right language. So I find this time now really exciting for patient advocacy.
We also have a recommendation in the chat to use different sources, like the same, to convey information in different ways, not only in the written, but also in let's say, audio records.
Multimodal.
And also use,
very good.
Multimodal.
Yeah.
And use the artificial intelligence and other tools to help people understand. And then, since we have only 5 minutes left, then we have a fantastic question which would summarize all our talk today. And it's, if there is one recommendation you can make to researchers involving patients in the increasing digital world, what would it be?
I can go first. I think that in my case, my recommendation is to involve the young patients. Of course, the parents, but the young patients, they have an opinion and they deserve to be involved and to participate as well.
Yeah, involve them from the very beginning and throughout the entire cycle. They are as important as the technological developer, because I always use the same example. So how many apps do you have in your phone? More than 30. How many of them you really use it? 10? Not even 10. So that's why when these people, they develop this application, they never thought about the user, the end user. And the end user in this case is the patient. As you want to start you have a great idea, you want to start a solution. So first focus on the need. So the need is not the researcher perspective of the doctor perspective, it's the patient perspective, the user perspective. At the end of the day, are going to use it, not you. So it's not for you, for your ego, it's for them. So this is true. I'm sorry, I'm very strict and blunt on this, but this is like this, and you need to involve them from the very beginning and throughout the life cycle of the solution.
Yeah, and if I may add, Ed, I think it's very important. Everything you give attention will grow, and if your attention span is just very narrow and for a limited time, you may have a nice project, but you want to have long-term impact. So if you want long-term commitment from individual patients, really lived experiences, give attention, involve them, inform them. Even if they don't ask, just repeatedly give them feedback on what is achieved with using your data. How will you and your fellow patients, profit from it, what it means. And this already makes a huge difference and ensures long commitment. I think this is also important.
It's hard not to repeat of these wise words, but I would also invite for an open dialogue. So sort of leave behind everything you think you already know and you expect from that contact, but just listen, with an open mind, and really think of patients as your partners and your true collaborators, that you are creating something together and they have something very valuable to give you and your research. So that would be my key message.
I think we are all very like-minded people, and I hope that with our passion we have sparked interest and made people believe that this is possible to engage patients in different countries, different backgrounds, and really work, because you, like researchers, have the talents and knowledge to make things happen for us, for patients, and we are all trying to make the world a better place, right? And I think, I really hope that we have sparkled the confidence that it is possible. And thank you all so much for having this time today to hear from us and to listen to our conversation. And if you have any questions, you can always find us through the networks or just on the internet, and stay in touch. Thank you.
Thank you all.
Thank you so much.
Bye-bye.
Right. Thank you.
Bye-bye.
Thank you.
No,
Bye-bye.
it is not over at this moment. Yeah, a big thank to all experts who joined us today. Really huge thanks to you. And even though this was an online event, your engagement was truly inspiring, but we encourage everyone to stay connected and follow EATRIS-CONNECT activities. There will be much more to come. And of course, we are looking forward to seeing you in person this October during the PMNet Forum in Latvia and Riga, and I hope that there will be the opportunity for even deeper and longer conversation. And Elise, do you have any closing remarks in 1 minute? I don't know.
No, I think you captured it really well.
Okay.
My only call to action was stay tuned. We have much more coming, and also just to express my personal huge heartfelt thank you for all the panelists and speaker, Ildiko, and it's like an Oscar speech. I'm not going to name all the names who were involved in making this event happen, but truly thank you everybody, and of course to everybody who made time to come and tune into this amazing conversation. Thank you everybody, and I hope you enjoy the rest of your Friday and your weekend.
Thanks
Thank
a
you so
lot.
much.
Great.
Bye-bye.
Bye everybody.
Thank you. Bye.